Thanks so much to Jacqueline Jansen, who is coming on with us today. She's an advocate for families living with mental illness and a leading voice for collaborative mental health reform. A member of NSSC, she serves on the Policy Action Committee and is also the Policy Director for California. She's a former director of the National Alliance on Mental Illness Board, commissioner on the County Mental Health Board, and one of the creators of the Family Partnership Policy. Her fifth book, Every Homeless Person Has a Mother, will be released in fall 2025. So I believe she said sometime before the end of November, she's expecting, citing evidence that including mothers and families in recovery and in collaboration with clinicians, homelessness can be prevented. A UC Berkeley graduate, she is a member of the International Association for Feminist Economics and for decades placed leaders in organizations for social justice. She travels the globe with her husband, witnessing cultures Americans would consider impoverished, but where homelessness is rare due to the strength of families. So, for print, you can learn more at jacquelinejansen.com and her Substack, Every Homeless Person Has a Mother.substack.com. And so that you get spelling and everything else correct, we will put that in chat here shortly. So without further ado, here is Jacqueline Jansen.
Hi, everybody. Wow, this is so great. Thank you to National Shattering Silence for inviting me to introduce the Clinician-Family collaboration. I want to thank a couple of people who have helped put this together, and that would be Anne Corcoran of Shattering Silence, and also a dear friend who's gone now, Edmund Creekmore, who invited me to do this and really helped me put this together. The first thing that we want to talk about is why there's an idea that clinicians and families should participate. But we know that sometimes it just happens naturally and it makes a big difference. The way that it happens, as you all will be able to tell us, is that we just start talking with each other. And we all have the common goal of making sure our loved ones are taken care of. I came into this about 22 years ago when my son was diagnosed as having a mental illness. And the only way that I could get treatment for him at that time, because he didn't really think he did have one, was to have him put into a program, a new program in the county, and that was to have him arrested first. So he wasn't really that happy with me, as you can imagine. And he did pretty well in that program. At some point, they came to me and asked me to kind of step back and not participate so much with him. And they told him that they were his family now and he should sort of step back from the family. And I did that because I wanted to be a good person, really pay attention. I trusted the medical system. Later, I learned from him that he felt I had abandoned him. And a couple of years later, in his group home, he was told that he was pretty high functioning and he needed to give up the bed for someone who had more mental health problems. And so they basically evicted him with not much planning. I did stay in touch with him and he did continue to contact me and come over once in a while, but eventually, roaming the streets, he ran into folks who were homeless. They were fascinating to him. They didn't have to take their meds. They could do what they wanted. They had a family of sorts in each other, and he joined them. And 10 years later, it was a pretty dire. And I really did not know what to do. By this time, he was coming over to my house, sometimes in the middle of the night, bloodied, having been in battles. And there was really nothing for me to do. But I started to learn. I had been learning all the time. I'd been a member of NAMI. And I've learned that there are a lot of things that we think about mental illness that really just aren't aren't true. And I would like to pass this on to folks. Maybe some of you who are joining us today are seasoned and you know these things, but in the future, if this gets out to people who are just getting into the system, they probably think there's a mental health system and that help is immediate and that medication will solve the problem. I certainly did. I thought, just give him a couple of pills and he can come back on the weekend and be part of the family again. They also think eventually that HIPAA is a barrier. And also, one of the biggest myths is that only the person with mental illness needs help. And we can agree, we do agree, clinicians and families. We do believe that clinicians are essential. Our kids can't recover without help. We also think mental health should be on parity with other diseases. Most of us, I think all of us on this call, believe that we should have clinical care, not let our kids go to jail for treatment. And if you've been in it long enough, you realize recovery is a journey. One of the things I began to learn from clinicians is that they have their problems as well. It's not just us, it's not just our adult kids or our kids. So I wanted to know why, what was happening with them, and I began to ask. And I learned that 30% of the clinicians, approximately, more or less, depending on what you find out there, but they're leaving their profession. Why? Because it's just so stressful. They don't feel supported. I know I've been plenty mad at clinicians in the past. And if they're not seeing recovery because our mental health system lags behind other diseases and solutions, they don't feel fulfilled. They don't see recovery and they don't feel like they may be doing such a good job. Also, with the turnover, they don't see the results. Families, well, it's a tough road. It ruins some of our relationships. I've lost some friends over it because in the beginning, was just so distraught and it was hard for them to take. I didn't lose my business, but I almost did. A lot of us began to have to take medication for things that we didn't experience before, like trauma and PTSD and depression. And we worry about our future health. Well, there are barriers to all of us working together. And when I talk to clinicians, I get these things. It's a disruption to them. You know, this is not the way they've always done it. And some of them will just cross their arms and say, you know, why should we change? We don't have the time. What about the patients of ours who say no, they won't work with their families? And what about the families that are so angry and traumatized and the ones who really shouldn't be with their adult kids with mental illness? And how do we build trust with our patients if we go to you and talk to you and our clients tell us they don't want us to? And then what about anosognosia? There's not much known about it. There's not been much research about it. The LEAP Foundation has done a lot, Dr. Amador, but still there's a lot of misunderstanding about it. And one of the other things is HIPAA. A lot of misunderstanding about HIPAA. But we families do know that we've been kept out of the relationship with our kids and helping them when HIPAA is cited. And what about the families that just give up? They just can't take it anymore. They've just had one too many problems and they can't fix it. And so they just have to disassociate themselves. Clinicians we know don't have enough time. Often they're overworked and they don't have the capacity for all the clients that are thrown at them. I have a friend who's a clinician who told me that someone called her one day and she didn't even know this person was on her list. So that can be very disconcerting. And if they have to throw families into it too and help the families, how could they possibly do it? But here's the thing. We need to get together with clinicians and really tell the truth about it because the mental health system isn't changing. It's a big ship. And there's bureaucracy. They say bureaucracy is just people, by the way, but it just doesn't seem to be changing. We're in our county here in California, we have a pretty darn good mental health system. And if there's anything that can be done, it's being done. But still, without a collaborative system, clinicians are on their own, families are on their own. So what do clinicians say? I've been told they think that families think immediate healing is possible. And it's their fault if our kids don't. When I say kids, I mean adult kids. There's no good word for that. If someone knows it, please tell me. So I'll call it adult kids, that they, if they don't heal, clinicians believe we think it's their fault. They think that we want information about our kids, like information they can't give. And this is true from HIPAA, they can't give personal health information. And they think that they think we use HIPAA to keep them out. Well, I think that's all true. We do have those thoughts, and I certainly have said those things in the past. But what do families believe that clinicians say? Well, families think that clinicians think we're the cause of the mental illness, especially the moms. And there's a lot of evidence to show that in the past, even now, we're talked about as refrigerator moms, and different kinds of ways we're talked about. It's not as bad as it used to be, but still. They say we're too emotional, we think, or we're over involved, or we're codependent. And we also believe that they think that we don't matter. But none of that is true. It can be true, but doesn't have to be true. Clinicians offer what this says, the expertise. They stabilize our kids during relapses. Just their presence is good for our kids, and they do know where the resources are. They do have the training. But we bring something too. We bring continuity. The one thing that we are experts in is never giving up. We'll always be there. Some families have, but that's just a small percentage. It's just a small percentage of families that can't be in the same room with their kids and shouldn't be. It's just not the bulk of us. Maybe it's 20%. I think it's less. So 80% of us can help. We're aware of changes. When we see something happening, we see that the medication is not being taken. We see that they're depressed. If they've lost someone close to them, we know that. And we provide family and love and belonging. It's just something that can't be replaced. There's nothing like a family. We forget about it sometimes, especially those of us who have families that get together. But everyone needs a family. There's not one person on the planet who doesn't. I look at the homeless population and I think everyone that's out there has a family that's fallen apart. We also advocate, and we can advocate for the clinicians to have better working conditions, less clients, more time. You know, when I started out 22 years ago, it really wasn't said that families were part of the solution. But in the last many years, through research and evidence, they're finding that families are just key to success. Doug Turkington, who gives the CBT training with NAMI, has said that, as you can see here, families are the greatest undeveloped and unused treatment and recovery option. I just think, what if the clinicians could use us to help them? What if we knew how to talk with them so that when we're at a point where our kids are really struggling and about to relapse or in the hospital, we can provide some support for both the clinician and our kids. But according to Cambridge University, family intervention stops the relapse, reduces it. And World Health Organization has said over and over in the last few years, we need greater collaboration with families. But this is just a small smattering of what's out there. I just didn't have room on this page to put it all there. But if you go on my website and you need ammunition for it, you'll find it. We have strengths. Together, we can do some things that are not possible by ourselves. Because we know that clinicians care. They went into this because they really care about people. Maybe they've had a family member themselves. And I would like to see families having a little more compassion for them. And then we stay. And our numbers do matter. If we were to get together with the group of people in this country who are family members, 1 out of 5 has a mental illness, and the other 4 are family members. But there are the nonprofit staff, there are all the clinicians, and we are a huge number. 770,000 homeless last year, and they all have families. Were we to get together and be a number of people, we might be able to make some changes in the system for clinicians and for our loved ones. I talked about that we blame each other. Clinicians have more clients than they can. Almost 30% of them are leaving the profession. When they're asked in surveys, are you planning to leave within the next 3 years? Yes, 30% say yes. And here's something that we don't often think about as family members. HIPAA is not the culprit. And the other thing that we don't know is that 50% of the homeless succumb due to mental illness. If you ask the homeless, if you do a survey, 50% also have been in the foster care system. And if kids in the foster care system don't have some kind of a traumatic experience, it would be very surprising. What clinicians and families both need to know is, it just seems so obvious, but no one is at fault, even the system, because the system is made up of people trying to get it right. HIPAA is often misused. And then finally, again, the family is integral to the wellness of each family member, and the health of the family depends on the wellness of its members. We say that in the family partnership policy in Marin County. But let's talk about HIPAA. I went to the trouble to read it. Oh, so boring, and there's a lot of it. But here's what I found, and I think many of you tonight here know this and understand it, but it's amazing how it's not known. It really is up to the clinician to make the decision about what is threatened harm and imminent threat or danger. And if they see that, if they believe that's happening, they have the right, whether the patient has given their permission, to talk to someone who can lessen that harm. Now, what does that mean? That means when someone is psychotic, they can't determine their own best health care. When they've been determined to be incompetent to stand trial. When they're in a hospital ward and they're not making the clear decisions, it is the clinician's decision. And HIPAA says that they would not go against a clinician for making that decision. That's huge because we now are told sometimes when our loved one is in the hospital psychotic that they can't let us know whether that person is there or not, even if we've dropped them off ourselves and we've talked to the person who is now telling us that she or he can't let us know if they're there. And so I'm going to urge everyone who's a family member to take this with them, and you can download it from my website. And this is not just my opinion. In fact, I just want to say none of this is my opinion. Not one thing I'm saying here. I have citations for everything. And sometimes more than one for the same thing because there are many people trying to make this work. And imminent danger is also homelessness. If they can't provide shelter for themselves, that's a threat. That's imminent danger. And so when a hospital lets someone out on the street without ascertaining who the family member is, then they've got a problem if one of us would take action. And now there are some lawsuits and suits that have been won for letting someone out on the street and them being harmed. I want to talk a little bit too about HIPAA. They say that there are HIPAA violations and you don't want to get involved in that. But if you can go on the website and find all the HIPAA violations in the country year to year, it's very rare to find one against a clinician. Maybe they can get fired for it, but that's an error on the part of their employer because it really is their right. They get to make the decision. Well, why wouldn't they? They're the clinician. They're in charge of our loved ones' mental health. So don't let them tell you that you can't have the information. Now, again, I've heard people say that clinicians won't take information from them. And in fact, I've had that experience myself, but that's not true. HR 2646, they are able to take it. And when you give it to them, you need to make sure you write down who you gave it to, when you gave it to them, and what you gave them. Many NAMIs now have forms on their websites that you can fill out for the history of your loved one. Well, what do we need to do to be able to collaborate, really? You know, how do we build trust? How do we become partners and not problems to each other? How do we share the responsibility so that everyone stays in their own lane and we're not trying to do the job of the therapist and they're not keeping us from doing our job as families? How do we get that transparency? How do we get respect for our lived experience? Well, we need to talk. Oh, we need to have conversations together. It's awkward, I think, at first, but my plan is that we form groups that come together and just talk to each other. Because by getting to know each other, we'll know what each of us needs and wants. And it doesn't mean that families will be in on every single therapeutic conference. That isn't it at all. We mostly don't even want to be. We don't need personal health information. We just really want to know that if we're needed, we're contacted and that we can help the clinicians know if there's a problem. But recovery begins with connection, and I think that is clear to all of us. This is not just my good idea either. Clinician and family collaboration exists. It exists all around the country and around the world. It's just that in many counties, it's kind of unheard of. The blame is huge. But Open Dialogue is a wonderful program in Finland. 84% of their patients, as you can see, do have some kind of recovery. And then the LEAP Institute, NAMI has great programs. Miracle Messages is an organization that goes out into the homeless encampments, sits down, talks with folks, and they say to them, where are your families? And, so many of them say, well, I lost track, or I'm ashamed, or they had me put in jail. But these people at Miracle Messages, they have reunited over 1,000 people today, and 60% of those have found housing, are now housed. And that's not because they go live with their families, but it's just because the self-esteem is built. And I don't have to tell you that about how good your family makes you feel. Also, here are other programs around the US that I didn't realize about, that most of the drug abuse and alcohol abuse uh, programs for healing include a family component. They ask the families to come. How is that not done in the mental health realm? But it's working. So we're not trying to recreate something that hasn't already been done. We just want to bring it to the forefront and make some protocol for having it happen. So for the mental health group, we could call it a new model. Clinicians can be certified to understand family inclusion, family integrated healing, and families can be sure to get their own training from NAMI in different places and CBT training. There are a couple of different kinds of therapists that you all may know about, of course. They're the ones who treat the individual and the ones who treat the families. And individual healing may work on some levels, but it's not the full thing. Dr. Josh Coleman, who's a person who works with estranged families, said the other day in a Substack piece, how can you divorce yourself from your family if you know that it's going to cause your mother pain for the rest of her life? Isn't there? And so I say, isn't there some way we can learn to reunite, to forgive each other? And that's the work at hand. I personally don't believe anyone is really healed until the whole family has some healing. So this is what I'm advocating for: recovery for everyone involved, defining some roles, setting some boundaries, having people be supervised. In other words, if a family member is acting inappropriately, that could come to the forefront. And the same for a clinician, and definitely the same for our loved ones, because I'm just going to say this. Sometimes our loved ones can be a little manipulative. I whisper it, but it's true. And I think you all know that. And we succumb to that because we just want them to be helped. So with a team, with a clinician and family watching, sometimes that can be mitigated because they know that they can get what they need a different way. Here's what we can't change quickly. Well, we can't change the bureaucracy. We can't change laws, regulations, and insurance barriers. There are some of our loved ones whose illnesses are really too advanced or entrenched. And there are families who are too traumatized with their own mental health issues. And clinicians talk about this. They say, yes, there are some families that we really just can't help. And we know that, but it is not the majority of families. I've seen some clinicians cross their arms and just say, we can't involve the families. They're just never going to do it. There's a lot of stigma about families, just like there is about mental illness. And then there are complexities in mental illness that we can't deal with. We haven't had the research and we don't have the solutions. But things that we can work on together are things that we bring our own unique skills. We can create a team. We can share our achievements with the group. We can let the clinicians know when our loved ones are doing well and give them a boost and let them know they're succeeding. We can make a change. We don't need permission from the bureaucracy. But we do need to just find times to get together. A few clinicians, a few family members, and just talk about what will work. We're holding focus groups to see how it would be to have actual gatherings. I mean, I don't even know that they're trainings because everybody really knows what to do. It's just a matter of talking, setting some boundaries. And we can make it part of the curriculum of the county mental health department. Our county mental health department is considering including this in their curriculum. And it is part of the family partnership policy that clinicians are trained in family inclusion. So what we just need to do is start where we are. Would love it if we could create a national certification for clinician and family members. I'd love it if it was embedded in the housing and prevention strategies, because wouldn't it be great if by our working together, we could prevent some folks from becoming homeless? Our homeless population grew by 18% last year, and it doesn't have to, since 50% of those entering are dealing with poor mental health system and the lack of family. So there is a method that we're working on. I could go through that, but I don't think we want to do that today. I'll call that part 2. I'll just quickly show you the screen. These are things that we're working on, but nothing that we want to go through today. I want to put some resources in the chat that you can download PDFs from this. I have a survey that I'd like you to take. It's for family members and clinicians. We'll get more information about what could work. You can go to my Substack for different articles and essays on this. And if you leave your email and request for this presentation, I'll send it to you. And I think Anne and NSSC will send it to you too, since you've been here. So I just want to thank you and ask if there are questions.
Hey, Jacqueline, I've got one question for you. Can you tell me, what does HIPAA actually allow clinicians to do?
Okay, well, that is a good question. And let me flip back up here to the slide, because this is what we have. So HIPAA allows clinicians to make the decision about what is threatened harm and imminent danger. This is written into the HIPAA law. And the HIPAA law is 164.510B3. I didn't make this up. Clinicians have the right to do that. And it says in this, we wouldn't think to override a clinician's expertise. So that's one thing that it does. And then a second thing is that, I want to say also that imminent danger is determined state to state. HIPAA does say that if your state has laws that are stricter than something that it prescribes, then you have to stick with that. But in our state, in California, our laws about that just practically mirror what HIPAA is saying. And then clinicians can receive information from family or friends. And here's another thing that I didn't list here, but clinicians can talk to family members. The only thing they can't do is give out personal health information. We're not asking for that. And here's another thing. If if a client if a client tells them, no, I don't want to talk to my family. Well, I'd really like to go back and see what the question was that was asked. Because some clinicians tell me that they say things to their clients like, hey, I could learn a lot more, and I wouldn't tell your parents anything you don't want me to know, but it would really help me to help you if I could talk to your family. Would that be okay with you if you knew I wasn't going to tell them anything you didn't want them to know? And this several clinicians have told me that about 20% of their clients might say, no, I still don't want you talking to my family. Well, that's 2 out of 10. So that leaves 8 other families they could talk with.
Jacqueline, I have a question. This is David.
Hi, David.
Hi. In order to better use family members in a therapeutic process, wouldn't what do you think of just advocating for better use of existing family therapy processes for where basically multiple family members attend a therapeutic session so they can talk together as a group with a therapeutic mediator? I mean, that therapists that do family therapy is something that already exists. And maybe, what do you think about advocating for more use of that to help better utilize the insight of family members?
Yeah, well, that's the key to it. That would be great. The And that does happen. As I said, there are organizations that use that, and there are therapists who use that model too. Um, and that would be really great if that was the norm, but it does not seem to be. From the family members that I listen to all around the country, and I'm on many groups, some with 12,000 people, 10,000 people, families really feel like they're being kept out. They don't know when their kids are let go out of the hospital. Um, they're not being encouraged to participate, and nor are their kids. And so, and again, when I say kids, I mean adult kids. And so, yes, that is the model that could work. And that's what open dialogue does. They start from the very beginning at the first break. And that's when they say it works the best. Because at that point, people are open to whatever it takes to feel better. Of course, we do know about people who won't agree that they have a mental illness. And some people are too afraid, as you and I have discussed in the past, to want to be with a therapist or their family. So we're not, you know, we're talking about what maybe to you would be an outlier, and to family members is the norm, not being included.
Noted. Also note with the HIPAA, Health Insurance Privacy Act, HIPAA, there are exceptions for what are called exigent circumstances. So if there is an immediate threat to health or safety, or someone is in immediate danger, the rules of HIPAA do not apply. And you
Well, excuse me, let me stop you there. That's just what we were talking about. It's 164.510B3. The rules of HIPAA do apply, but the rules say that if that is the case, the clinician can make the decision. And you're talking about exigent dangers. Mhm.
Exactly. An
Right.
immediate pressing danger
That's right.
to self or others. A
That's
physician
right.
can share information with other people and not be prosecuted or charged for doing.
Absolutely. And that is very clear in HIPAA. And we family members just, most of us, many of us don't know that.
Many
So
physicians don't know that either.
many, right. And that was one thing that I was told in one of the counties that I was talking with the director. He would like his clinicians better informed about HIPAA. Um, you know, the imminent danger includes being unable to take care of yourself and even being without shelter. So again, when they let someone out of a hospital with no place to go, no plan, no money, no housing, it's illegal, first of all. It's a federal law that hospitals can't do that, but it's done all the time. And I don't have the exact statistics on that. So when I say all the time, I apologize because I don't have those statistics, but I can get them. But yes, you're absolutely right. This is something that it's just so little known. Beth, did you have other
I've got
questions?
another one. Can you tell me, in what ways does involving families ease clinician stress and improve retention?
Well, we do know that clinicians are have heavy caseloads typically, other than private clinicians who can make their own decision about how many people they want to take. But if you're talking about a county system, they generally have more clinicians and more patients than they can. And if the families are involved and it's said to be true and evidence to be true that they can help alleviate relapses, it would give a clinician more time if they're not dealing with someone relapsing. And if families are involved and their loved ones are recovering more quickly, and the clinicians know about it, wouldn't it make their job like they're doing a better job, give them more job satisfaction? Because that's something that they're saying they don't have right now and why they're leaving. They're just burned out. Do you think that answers the question, Beth, or is there a follow-up that you would?
I think so. Um, how can a clinician maintain therapeutic trust while bringing families into the circle of care?
That is a good question because it is a learned skill. I believe it's a learned skill. Right now, when someone is admitted into the psychiatric hospital, a question is something like, you don't have to have your family involved. We don't have to notify your family. That is not the way to say it. A good clinician will say, I'd like to know a little bit more about you and your family and see if what we can learn to help you. Can I talk with your family? I won't tell them anything you don't want me to tell them, but I'd really like to know the best way to help you. That is what at least a psychiatrist, psychologist, and a few other clinicians have told me that works. And they act like they frame it like this is how it is. This is the way we go about things. We make sure that everyone is included and helped, not at the cost of your privacy, however. But some clinicians don't know that. And some clinicians are not even aware that families do make a difference in recovery. It's not taught in the schools. I also understand things like grief isn't taught in the schools either. So we know when our kids are grieving, they're grieving their loss um, of their faculties, the life that they thought they would have. But they need to blame someone. And so we are the ones that get blamed. And of course, so then again, then they can tell the clinicians, no, I don't want them. I'm mad at them. They're terrible people.
And my son, who's 47, is schizoaffective diagnosis and understands and has got a great psychiatric nurse. So what I want to say is it makes so much difference that she included me at the end of his first session. And I have good communication with my son, and we've come to some agreements about how much or when or whether I'm to be included, which I don't need to be at this point. And I just want to say it makes such a total difference. And the first time 7 years ago, first episode, it was the opposite, with somebody who was new and just didn't feel like comfortable with really hearing anything from me. So just I appreciate the work you all are doing.
Thank you, Leslie. That's so good to hear that. Wonderful. Is there someone else, Beth?
I was looking. I want to just read somebody's remark. Heidi says, very valid points about breaking down the barriers between families and clinicians via relationships. When it comes to HIPAA, the clinicians do not want to make the decision because it's too risky. They go with the rules that the lawyers who work for the hospital corporations tell them. They are caught in the middle. That's her comment.
Oh, thank you so much for saying that, because I don't know all of the ways that that clinicians are stopped, but this is why I want to get the word out, because they have some autonomy. And if they knew the statistics about family involvement and that families make such a difference in recovery, they might be willing to butt up against some of those lawyers. But I do think that it needs to be known far beyond this small group and our county, and it needs to be in the public domain. Families are just forgotten. Like I said, the ones who make it as families, no one gives it a second thought. But mostly the folks who have financial problems, trauma problems, um, generational problems, they don't have the tools or the skills to keep their family together. Those are the ones that, that hurt. And there are other families too that not only they don't have financial problems, but they just don't really care that much about their family. They're off buying things. So I think it goes all the way around, and every one of our cultures is affected by mental illness. But I think it's true, this person who's mentioning this, that the word just needs to get out, because we don't want the clinicians hampered anymore.
Gotcha. I want to ask you a question as Beth Wallace. So my loved one has anosognosia. What is something that I can do to improve my relationship with him? And two-part question. How do I work with the clinician that really has never heard the word anosognosia? They refer to it as lack of insight, which is fine. But I'm kind of at this really sticking point, as a lot of us are. Can you help me out there?
Beth, that is something that is so widespread, and 20 years ago, it wasn't even a word that we knew. But when I first heard it, I was at a NAMI event, and there was a psychologist talking, and he mentioned the word, and I went to him at the end and asked him, okay, so what are you doing to find out how to deal with this? What's the solution? And he just looked at me so blankly. And for him, there was no solution. That was just a way to sort of say, I can't do anything. It's anosognosia. I can't do anything. It's the HIPAA law. We have to learn to advocate. Our voices as mothers are a bit frozen because we've been turned down so many times, not just in the mental health world, but if you've lived as long as I have and you haven't, you you will have come up against this many times where we're not listened to. And it just gets to be where you just don't want to say anything. But Beth, I think I can send you a document, or maybe I'll post that on my website, a document about what anosognosia is, a very well-written document, and give that to them and ask to have a conversation with them just ask if you could sit down with them and talk about it. Now, that's one part of it. The other part of it is that Doug Turkington's CBT training does address that, as does the LEAP training. And he did training for NAMI Marin, and I think they're going to, I know they're going to try to get that to be a national training through NAMI National. It was brilliant, fantastic. We learned so much, and in it, I did learn much more about how to deal with my son, how to talk with him, he calls it befriending.
Did you say Doug Turkington?
Yes.
Is that right? Okay.
Doug Turkington. I'll put the link in the, or send it out to everybody when this is posted. So there are some ways to deal with that. And it's not surefire. Doesn't happen overnight, but I've seen it work myself.
Okay. I've read through LEAP, so I understand what you meant by befriending. So thank you for that. And it looks like Michael is next. Michael, I don't know how to say your last name. I'm sorry.
Neither do I. It's Hungarian. First, Jacqueline, thanks for your presentation. I so much agree with everything that you're saying. I do have a direct answer to your question, Beth, about how do we get our loved ones to trust us? Because yes, we can try to form groups and talk to clinicians, but where the rubber meets the road is, do our loved ones trust us? And frankly, they don't when we keep telling them that they're sick and they need help. And Amador has it right for therapists, but what he doesn't understand, because he doesn't have the direct experience, is we family members, we have 20 or 30 or 40 years of experience and relationship with our history, or relationship history with our loved ones, where the therapist doesn't. They start on day one. So as family members, we need to go through a whole bunch of what I call relationship rescue steps in order to rebuild that trust. And there is a class that I teach that does exactly that. And you can go to patreon.com/SMI caregiver, which is my Patreon site. It's free to join. The next class starts January 10th. I've trained over 100 people over 5 years, and it works.
Oh, I so appreciate that, Michael. We really are looking for all the ways that we can collaborate, because no one has all the answers. But I've been thinking about this recently. You know, our kids are sensitive. I think any one of us would we would tell each other our kids are sensitive. They're so smart. They know, they have a nose for knowing what's true, what's, honorable. And I think kids sometimes see us, even just saying, when we pick up the phone, oh, my husband's not home, when he's standing right there. There are 1,000 ways that we betray truth, and we don't even think of it. There are horrible lies which are being told today in this country, but there are also tiny little lies that kids pick up on. And I think if I'm thinking about what you're doing, and if this is to rebuild trust, I found that my son being diagnosed with this mental illness gave me an opportunity to really try to right my own integrity in so many ways. And I don't consider it a blessing at all. And I hate it when people say, oh, you get something good out of this. No, I won't. But the thing is, I do feel like there have been a few good things, and one of them is rebuilding trust. So thank you for that. I'm going to look it up and put it on my website. Michael, thank you very much for saying that.
One other thing, and that is something you mentioned, that there is evidence about when our loved ones trust us. Dr. David Miklowitz, who's a clinical psychologist on the faculty at UCLA, has done a study, first with schizophrenia and then bipolar patients. Here's what he found. Loved ones who have caregivers with what Miklowitz calls high expressed emotion. That's blaming, criticizing, making fun of our loved ones. You're sick, you need help, stop behaving that way, all that kind of stuff. Those loved ones have a 94% probability of requiring another hospitalization in the 12 months after their last one. 94%. Whereas loved ones who have caregivers with low expressed emotion, in other words, high emotional intelligence, we don't blame our loved ones. We don't tell them they're sick. We respect their dignity and their agency as adults. Guess what the rate is? 17%, 500% lower recidivism rate for hospitalization. That means lower hospital costs, faster recovery, less cognitive brain damage. It's just amazing.
Well, Michael,
Miklowitz,
yeah, I've
LLW.
written this down too, and I'll get that from you so we can put it in the resources. But this is brilliant. It is true. I think then that Doug Turkington and Dr. Amador are onto it as well, talking about not saying there's something wrong with you and just accepting them, because I think when you look in people's eyes and you accept them for who they are, just the way they are, not even just the way they are, but who they are, that
They
makes a
deserve
difference.
dignity.
Yeah,
That doesn't matter that they have a serious mental illness. They deserve dignity.
absolutely. You're so right. Is there something else, Beth?
Yes, I've got two people waiting for you. It looks like Leslie Marks, if we could take her off mute. Leslie, you might be able to take yourself off.
Yeah, I did.
And you
Okay.
should be able to open your video also, Leslie.
Okay, I'll give it a try. Oh, here I am. So I just wanted to add a little postscript about Dr. Turkington's work that was a pilot program and has been so wonderful and good timing for me at the time that my son was hearing voices. And just the approach where you can talk and you can tell, like Jacqueline was saying about looking in their eyes, and when there's an opportune moment, you can ask questions like, do you know what the seed of this, like when things changed a little while ago. And I did that with my son, and he immediately knew and shared that. So, and again, being sensitive to the individual and the relationship. And I'll add one more thing. At one point, before the second episode, my son, because we used to do this when he was a kid, family meeting, and I would share with him my appreciations of him about qualities that he had. And that has also been really helpful. And his are always very heartfelt. So thank you.
Thank you, Leslie. That's so wonderful to hear that. I'm so glad he's doing well.
Coming along.
Someone else, Beth?
We've got Nancy. Nancy, you want to unmute and come on and turn your camera on, please?
Okay, there I am.
Hi, Nancy.
This has been very helpful. I come into this group from a different level of, my son has addictions, multiple sclerosis, and lifetime juvenile diabetes. So there's a lot of, so I'm focusing on the parents. I started a group of people from my church called Heart to Heart, where we meet once a month on the computer to talk about what we are going through, to normalize it, because I'm so sick and tired of the shame that surrounds addiction and mental illness. You know, like Jackie was saying about they blame the parents. You didn't raise your kid right. Well, we have 4 other kids that are doing just fine. but this particular one has just had so many challenges. And I really appreciate the clinicians. At first I thought, okay, as soon as he gets to a psychiatrist or therapist, he's going to be fixed. Well, no, that's not the case. And I too felt angry at the therapist that they didn't fix my son. Now I appreciate them so much for the work they do. It is not easy. And I want to preserve their careers and show the appreciation. So that's where I'm at. And that's it.
Thank you, Nancy. Wonderful.
Excellent. Hey, David, would you be willing to come back on and talk about your comment? You were talking around the time we were talking about anosognosia. Love to hear from you on the comment that you made.
Yes, there's different types of anosognosia.
Just
Let me
such
get
a
my-
deep topic. Love to dig down on your perspective here.
Okay, sorry
Oh,
about
I'm
that.
sorry. If I can interrupt, because I did not, Jacqueline is taking all the questions, but she's not seeing what was written. So I'm going to read it real quick. Anosognosia is a difficult term that can also be abused and used to gaslight people with mental health conditions by denying their rights to decline psychiatric treatment using toxic antipsychotic drugs that have severe side effects. People have the right to chart their own course. Disagreement on treatment decisions does not mean it is caused by anosognosia. That was his comment.
So my
Now,
point is,
but David, before you start, I just would like to say, I'm very interested in this, and I know you and I have discussed it. We have less than 6 minutes left, and I think this is a subject that needs its own webinar. So
I just need
something you
30
can
seconds,
say?
Jacqueline.
Okay,
Just
great.
30
Thank
seconds.
you.
So there's anosognosia caused by brain injury, where the brain is actually in a damage by physical trauma or injury, and that can cause traditional anosognosia. The use of that term has been broadened to include, often be used against people with mental health conditions who refuse treatment, who don't want to take a particular psychiatric drug, and they're labeled as not accepting their mental health diagnosis when really they've had toxic effects and they're rejecting treatment. So the application of that term has been, I think, abused and broadened beyond its original scope of lack of self-awareness due to brain injury. So that's what I wanted to say. That's all. That's it. Thanks.
Thank you. Thank you, David. I really do want to talk about this with you more too at some point. But yes, I think for the purposes of this, we're talking about people newly diagnosed who don't have an experience with any drugs or medication yet. They don't want help at all. So I think that's absolutely right. It's very different at different stages in your career with mental illness and as a family member.
I'm a family member listening today. What is one concrete step I can take tomorrow to start building collaboration with my clinicians and doctor?
Well, thanks for asking that. Not everyone has a clinician on hand. Sometimes they don't actually appear until there's a problem. But if you have someone with whom you work or your family member works, and you have an opportunity to chat with them or email them or text them and tell them about this particular talk that we're having, ask them what they think about it and see if you can get a conversation going. And if it's someone, a clinician that's been helping you or talking with you, please appreciate them and let them know that it's meant a lot to you and you would like to see your friends have that same kind of relationship. Ask them what they need from you. What would help them? What would help you, clinician? to have a better experience with your career? What would make things more fulfilling for you? When my son returned from the hospital about a year and a half ago, he was, I knew I could pick him up because the clinician called me. He didn't have to, but it was part of HIPAA that he was going to prevent my son from being homeless again. And so he called, and I got an opportunity to call my son and ask if he would like to come live with us. And when I called, he didn't respond at all. Nothing. It was silent. And the next week, the clinician called back and he said, you know, he's being released tomorrow. So I called my son again and I said, and this is because of Doug Turkington's CBT. I didn't try to push him into it or even ask him, wow, would you come live again? Why not? I just said, what are your plans? And he said, well, aren't you picking me up? Oh, that was such music to my ears. And I said, yes, of course I am. So he's home and he's thriving. And it was really because a judge, well, first the police department did well, a judge did well, clinicians did well. This particular clinician did so well. And after he returned to us, we had a team prepared and you know, he's really had some mentoring that meant a lot to him. But the thing that I think is kind of sad is that the hospital has not called to find out how he is because they could take such a win with this. I mean, I know it involved all of us, but it is a win for them too. So that's what I say. I would just feed them on every little thing, text them, email them, let them know that you appreciate them. That's a good way to start. You can start that tomorrow.
That's fantastic. All right, everybody, we are right at 8:15. If there are other questions, please, we've already given you Jacqueline Jansen's contact information earlier in the chat. But that's a wrap. Thank you so much for coming in and doing this with us, Jacqueline. Really, really appreciate your talk today. And also, questions could be taken by Ann as well, Ann Corcoran. So just as another means. Thank you so much, everyone. Take care.
Thank you very much, Beth.
Take care.